So good evening, everyone, and welcome to our Learn and Share conference call. I'm Russ Derry, the Director of Education for Epilepsy Foundation of Michigan, and I'll be moderating this discussion. The topic for tonight is epilepsy in older adults, and we're pleased to have as our speaker Dr. Rohit Marawar, an epileptologist with the Wayne State University and the Detroit Medical Center's Comprehensive Epilepsy Program. So, Dr. Marawar, can you briefly share your clinical and research interests and describe your experience with this topic?
Yeah, thanks for having me, Russ. Great to be here. My clinical and research interests, they span the many aspects of epilepsy, but the one that I'm most interested in currently are seizures and epilepsy in elderly and in people with dementia. I also conduct an elderly epilepsy clinic at Detroit Medical Center on second and fourth Thursday afternoons. We have multiple research projects ongoing at Detroit Medical Center in this field. I recently received a grant to look at EEG and MRI markers in patients with epilepsy and Alzheimer's disease and how seizures affect memory in these patients. So that's in summary my experience with this topic.
Great. Well, I look forward to hearing more about that research that you're doing. So for whatever reason, there is a public misconception that epilepsy is primarily a childhood disorder, but in fact, epilepsy can occur at any age, with incidence and prevalence actually being highest in seniors. So can you briefly discuss the epidemiology of epilepsy in older adults?
That's absolutely correct. There are two peaks for increased incidence and prevalence for epilepsy. One is in childhood, and the other one is above age 60. In fact, as per some studies, the peak after age 60 is higher than the one in childhood. And actually, we have known about this for more than 20 years, but as you said, there is still a misconception that epilepsy is primarily a childhood disorder. Now, many times when I see patients with new onset seizures in our elderly epilepsy clinic, they are obviously frustrated, sometimes angry, and at other times disbelieving that they had a seizure. And they usually say, but I never had one as a child. How can I have one now? And I have to, kind of reassure them and tell them that they are more likely to have a seizure than their grandchild. This is likely because the burden of risk factors that cause the seizures, like stroke, brain injuries, tumors, dementia, all these risk factors increases as one gets older. The incidence in elderly for seizures is around 12 people every 10,000 people versus around 8 in adults. And the prevalence is around 7 every 1,000 individual versus around 4.5 every 1,000 individual in adults.
Okay, great. So when we think about older adults with epilepsy, some of them develop it earlier in life and simply continue to have it in later life. And then there are also those who are newly diagnosed with epilepsy as seniors. So for those diagnosed with epilepsy as seniors, what are the most common causes?
The ones who are diagnosed with epilepsy as seniors, the commonest cause is actually similar to the one in your younger adults, which is unknown. Cause is unknown. Right. And this accounts for 30 to 50% of the senior patients. The next commonest is stroke, and this includes both ischemic stroke, which is due to lack of blood supply to the brain, and hemorrhagic stroke, which is bleeding in the brain. The third commonest cause of dementia, the third commonest cause is dementia, including Alzheimer's disease.
Okay. So can you talk about the risk of early or provoked seizures following stroke and the risk of developing epilepsy or unprovoked seizures following stroke?
Sure. As you mentioned, seizures can occur very soon, within a couple of weeks after stroke, the so-called provoked seizures, or they can occur much later, and these are termed unprovoked seizures. The risk is somewhat different for ischemic and hemorrhagic strokes. For ischemic strokes, the risk is around 4 to 5% for both, and more than half of those with unprovoked seizures will continue to have further seizures. For hemorrhagic strokes, provoked seizures are more common, around 8%, and unprovoked in around 3%. But most of the people who have unprovoked seizures will continue to have seizures in the long run. One important thing to know for provoked seizures, most will occur in the first 24 hours after a stroke.
Okay, great. And what are some key things that people should know about the relationship between epilepsy and Alzheimer's disease? I've never been clear on the directionality of that relationship. So if you could talk a little bit more about that, that would be great.
Sure. So first of all, people with Alzheimer's disease are at 6 to 10 times increased risk for seizures as compared to other people in that same age group. The onset of seizures seems to cluster around the time they start having memory problems. However, people who have both Alzheimer's disease and seizures tend to start having memory problems much earlier as compared to other Alzheimer's disease patients who do not have seizures. The good thing is that based on the limited data we have, Alzheimer's disease patients with seizures tend to respond very well to medications, especially levetiracetam and lamotrigine, and most of them are seizure-free or have seizures rarely. What is very interesting and we do not know is whether seizures are symptoms of Alzheimer's disease or whether seizures in some way cause Alzheimer's disease or at least hasten the process of memory decline. So that question is still in the air.
So it's also presumably possible that there's some common underlying process that could lead to both?
Exactly. So there might be a common underlying pathophysiological process that might cause both seizures and memory problems independently, and then seizures might be worsening that memory decline. There are some animal models which have looked at that, and as you may know, in Alzheimer's disease, there is a deposition of abnormal protein called amyloid beta. So there are some animal models which suggest that deposition of these proteins lead to seizures, and then the seizures lead to further deposition of this abnormal protein, and this cycle continues. But I do not believe this has been adequately demonstrated in human beings.
Right. Okay, so seizures in older adults can easily be confused with symptoms of other conditions seen in seniors, such as TIA or transient ischemic attacks, which are often called mini strokes too, dementia or sleep disorders. So can you talk about this and other challenges in diagnosing epilepsy in the elderly?
Sure. As you know, accurate history is the best tool we have to diagnose seizures. However, this can be a huge issue in the elderly population because of multiple social factors, including that many times they might be living alone, and so there might be no witnesses that have seen the episode. Sometimes a family does not accompany the patient to the clinic or the hospital, and so it's difficult to get history. Sometimes elderly people might have poor memory and cannot give accurate description. Another issue might be that patients who come to the hospital or clinic from nursing home usually do not have any accompanying information sent with them, and it can be extremely difficult to get this information from the nursing home. In addition, the clinical presentation in elderly is different than in adults, and we'll talk about that in a little bit. The other thing I want to point out that EEG, which is the best test we have to diagnose seizures, is less likely to be helpful in elderly, especially the 20-minute EEGs. There is some data that long-term EEGs like ambulatory EEGs or admission to the hospital, which is the epilepsy monitoring unit, these might be more helpful for diagnosing seizures in elderly. In addition, some normal variants in EEG might be seen more frequently in the elderly, leading to increased false positivity of the EEG. There are also multiple other conditions in elderly that can be difficult to distinguish from seizures, and these include syncope, which is basically an episode of passing out or loss of consciousness, then convulsive syncope, which is actually a seizure, but the seizure is because of inadequate blood supply to the brain. So you have to figure out why somebody is having inadequate blood supply and treat that rather than treating the seizure, but it can look very much like a seizure. Confusional migraines. So as you know, migraines are common, but in elderly, many times migraines can present just as confusion without a headache. Then TIAs, or as you pointed, mini strokes, can present similar to seizures. So there are all of these other conditions which make it sometimes very difficult, and in addition, EEG cannot be relied upon to make a diagnosis of seizures in elderly.
Right. And I can give an example, a personal example of my mother-in-law's husband had multiple conditions. He had Lewy body dementia and Parkinson's, and he was eventually diagnosed with epilepsy as well. But the one seizure that was what we witnessed was actually the postictal phase. So we saw drooping on one side, and we saw difficulty with speech and memory, and it may have been that Todd's paralysis or Todd's paresis, and so that's what we saw, and so it didn't. So we called in, 911 because we thought maybe he was having a stroke, and turns out that it was probably we missed the actual seizure, but saw the postictal phase. So it is very, very difficult, especially in older adults who have multiple health conditions.
Yeah, and if I would like to point out that in Lewy body dementia, one of the diagnostic criteria for Lewy body dementia is this alteration in awareness, which can be very prolonged.
Yep.
And so those episodes of changing awareness or attention can mimic seizures or can even mimic postictal state.
Right, exactly.
So personally, I feel in Lewy body dementia, it's all the more difficult to diagnose somebody with seizures.
Right. Okay, so given all of these diagnostic challenges, would you recommend that older adults with new onset seizures be evaluated at a comprehensive epilepsy center rather than, by a primary care physician or a general neurologist?
I think if there is a difficulty reaching a definite diagnosis, and as we just discussed, there can be a lot of different differential diagnoses, and seizures can be atypical. So if there is a difficulty reaching a diagnosis, or if these episodes need to be recorded in a epilepsy monitoring unit situation, then evaluation of these patients at a comprehensive epilepsy center can certainly be helpful and is strongly recommended. In addition, as we develop experience in our specialty elderly epilepsy clinic, we can address many other subtle issues related to seizures and medication therapy and psychosocial factors that frequently accompany elderly patients with seizures.
Okay. Can you describe the types, patterns, and symptoms of seizures most likely to be experienced by older adults and how this differs from younger adults?
So the commonest seizure type in elderly is the complex partial seizures. The second commonest is generalized tonic-clonic seizure, or commonly called grand mal seizures. The clinical presentation in elderly is different than those in adults. The elderly are less likely to have the typical hallmarks of seizures like auras, which are the warning signs, and automatisms, which include some rhythmic activity of your hand or some picking motion. So all of these, the auras and the automatisms in a adult can lead us to an easy diagnosis of seizures, but these are less likely to happen in elderly. which makes the diagnosis more difficult. Also, elderly are more likely to have prolonged confusion after seizures, like we just discussed. And so this prolonged confusion can be difficult to differentiate from subclinical seizures. And in people who have dementia, it can be difficult to distinguish from delirium. We think the commonest location for onset of seizures in elderly is frontal lobes, and hence they tend to have less likelihood of the auras and automatisms, which are usually seen in temporal lobe epilepsy. I think the overall all of these features make the diagnosis even more difficult.
Okay. Yeah. So a complex partial seizure in an older adult may simply just involve a brief period of unresponsiveness, and that may be
it might just
the only symptom.
Right. It might just involve some staring, and nobody might notice it.
Right.
And what they might notice is the accompanying confusion that happens after a seizure.
Okay. And are nocturnal seizures more common as well, given the higher prevalence of frontal lobe epilepsy?
That's a good question. I do not think that nocturnal seizures are more common, but I do not have I have not come across any particular study like that.
Okay.
Usually the nocturnal frontal seizures, they are commonly seen in nocturnal frontal lobe epilepsy, which is more of a genetic condition than a focal symptomatic epilepsy.
Okay. So status epilepticus, both convulsive status epilepticus and non-convulsive, is more common in older adults. Can you briefly describe the different types of status epilepticus and the associated risks?
Right. So as you mentioned, status epilepticus is more common in older adults, and many times the status epilepticus episode will be their first ever seizure. The different types include convulsive, which means that you have whole body shaking. The other type is non-convulsive, where you might just be confused or in a coma, and the only way to figure out if you're having a seizure is by doing an EEG, which shows the seizure activity. You can also have complex partial status epilepticus, and then myoclonic status epilepticus, which involves just brief jerks of your body, but that is usually seen with anoxic brain injury, many times after a heart attack or something like that. But both convulsive and non-convulsive, which are the commonest types, can be much more dangerous in elderly as compared to adults, because they tend to have multiple other serious medical comorbidities like heart disease, kidney and liver failure, and are more susceptible to hospital-related infections. In fact, the risk of death in elderly with non-convulsive status epilepticus is close to 50%. Now, acute or chronic stroke are the most common etiologies of status epilepticus in elderly, and patients who have an acute stroke followed by a status epilepticus have the highest risk of death. Some other risk factors leading to poor outcome include treatment with benzodiazepines, which are usually our first line or rescue medication for stopping seizures. This is likely because benzodiazepines can lead to problems with breathing and need for intubation, which then prolongs the stay in the ICU and in the hospital.
Okay, so in adults who have epilepsy, who then age with epilepsy and then have it as older adults, are they more susceptible to status epilepticus as well, or is the increased prevalence due largely to the association with other, acute conditions of older adulthood?
I think the age here is an independent risk factor for status epilepticus, whether your seizure started when you were elderly or whether they started when you were younger.
Okay.
but we know that for patients who have new onset seizures, up to 30% of the times, their very first seizure will be status epilepticus.
Okay. So with this in mind, do you have any general recommendations regarding the use of rescue medications in older adults with epilepsy?
I think as this data is based only on a couple of studies, benzodiazepines should still be used as first line or rescue medications for status epilepticus in elderly. But the important thing is I think they should be used in appropriate dosages, not too less and not too much. Too much benzodiazepine can lead to problems breathing and need for intubation.
Okay, and is that talking about things like Diastat and intranasal midazolam and Klonopin and those types of medication, or are you speaking more about in the actual hospital setting?
I'm mentioning more in the hospital setting.
Okay.
When patients are presenting with status epilepticus to the hospital.
Okay. Is there any recommendations regarding family members having access to rescue medications like Diastat or intranasal midazolam or any of the other like sublingual benzodiazepines or anything like that, or is that fairly those recommendations similar to what you would have just for adults?
I think the recommendation is similar to as what you would have in adults. If someone is, once we know that someone has seizures, if they are more likely to have a prolonged seizure, or if they are more likely to have a cluster of seizures, then using those medications like Diastat and Klonopin can definitely be helpful to prevent the seizures from getting worse acutely.
Got it. Okay. Now, because older adults metabolize medication more slowly and because they're more likely to be on multiple medications, treatment with anti-seizure medications can be more challenging for physicians and patients alike. Can you discuss some of these challenges and what can be done to maximize success and minimize both short-term and long-term side effects?
Sure. So a good general recommendation for any person is to be on as less medications as possible, obviously. But this applies even more in elderly, as they tend to be on multiple medications and interactions between medications can be common. As per one study, patients who take anti-epileptic drugs or anti-seizure medications are on an average taking another dozen different medications. In addition to the primary care doctor reviewing the patient's medications, I think it is good practice for the neurologist also to review the medication list at each visit and assess and communicate to the primary care doctor if any medications can be decreased or stopped safely. I should emphasize. Also, if patients are on older anti-epileptic drugs, the neurologist should assess if there are interactions with other medications. It is invaluable if you have a pharmacist that can work alongside you to help with all of these issues. But specifically as far as anti-epileptic drugs go, it is always preferable to start newer medications for three main reasons. Number one is that they are universally better tolerated as compared to older medications like galantin and carbamazepine. Number two, older medications are more likely to interact with other medications. And number three, older medications like phenytoin, carbamazepine, valproic acid, and phenobarbital have more long-term side effects like osteoporosis, which is decreased bone thickness that makes it susceptible to fractures. And some of these medications can actually also cause increased cholesterol. Now, talking about bone health, patients who are on these medications, these older medications, should always be on vitamin D and calcium supplementation and should have their vitamin D levels checked regularly and DEXA bone scans every 2 to 5 years. For the anti-seizure medications, it is easier for elderly to remember to take the medications that are once a day as compared to twice or 3 times a day medications. Also, if I personally feel that patient has memory problems and no one else to manage their medications, I tend to avoid starting lamotrigine as it has a complex regimen in the beginning, and so it might be confusing for the patient. In elderly, it might also be important to see that these patients are seen in follow-up sooner than you would otherwise see adult patients to assess for compliance and tolerance of the newly started medications.
Right. Can you talk briefly about toxicity and what family members can look out for or be on the lookout for, just because that's more common in older adults?
Sure. So all seizure medications can cause fatigue, and most of the seizure medications can cause dizziness. Now, dizziness can sometimes manifest as loss of balance also, so that's something to watch out for. Sometimes any medication can cause rash, especially carbamazepine and lamotrigine, where rarely the rash can turn dangerous. Phenytoin is very commonly prescribed in elderly, but it tends to fluctuate a lot in the body for reasons that are unclear, even in patients whose dose and other medications remain stable. And if phenytoin level increases, that can manifest as vision problems, difficulty with coordination, loss of balance, and so forth. And obviously, if you're on multiple medications, you might be drowsy and not alert, and this obviously can lead to falls.
Right. Okay. So overall, what is the prognosis for those who develop epilepsy as older adults?
So most of the research we have in this field suggests that patients who develop epilepsy as older adults tend to have better outcome in that their seizures are either rare or that most of them are seizure-free. However, elderly who've had one seizure are more likely to have a second seizure. That is, they are more likely to develop epilepsy after their first seizure. However, it is important to note that even a single seizure can be dangerous in elderly. Even a single seizure can make them lose their independence and can lead to premature admission to nursing homes or assisted living facility. As we just mentioned, anti-epileptic drugs are also associated with increased risk of falls. And as we discussed, some medications can affect bone health. And so these patients are at increased risk for fractures. Elderly, as expected, have a higher likelihood of side effects, as we discussed, and the incidence varies with the different medications that are used. Many older AEDs, including phenytoin, carbamazepine, and phenobarbital, can also cause cognitive side effects. That is, it can interact with their alertness and it can interact with their memory. It can affect their memory.
Right. Okay. So when medications have failed to provide complete seizure control, to what extent can other treatment options be considered in older adults?
Russ, as you know, patients who do not respond to two appropriate medications are termed medically intractable, and they're unlikely to respond to further medications. Now, elderly tend to have less number of medically intractable patients, but who do become intractable, they have other options like vagus nerve stimulation and epilepsy surgery. There has been only one study looking at vagus nerve stimulation in elderly, and it seems to be effective and tolerable in elderly. However, before vagus nerve stimulation, epilepsy surgery should be considered, and the multiple studies that have looked at surgical outcomes in elderly have shown that the success rate is as good as adults. There might be a slightly increased risk of verbal memory problems after temporal lobe section in elderly. In one study, however, elderly who underwent surgery had improvement in quality of life and were happy that they actually had the surgery. We do not have enough experience with responsive nerve stimulation, or neuropace otherwise called, and ketogenic diet in elderly to make a meaningful statement.
Yeah, and I would think in theory, an older adult who had severe disabilities and was, on a very restricted diet anyways, or had a feeding tube or something like that, that maybe in that situation it wouldn't be unreasonable to consider the ketogenic diet. But I'm guessing, again, that's so uncommon that there's really no data on that.
Yeah, I think that's a reasonable thought. In sometimes we see patients who are very disabled, as you said, and have a feeding tube, and they need long-term acute care. Yeah, in these people, if they're having constant seizures, a modified Atkins diet or ketogenic diet can certainly be considered.
Great. Okay, so we've been speaking to this point mostly about older adults with new onset epilepsy, but now I'd like to talk specifically about people who've developed epilepsy as children or as younger adults and then continue to have epilepsy into older adulthood. Are there any changes associated with aging that might contribute to changes in seizure patterns or types?
So we have limited information on how seizures or epilepsy evolves as one goes from childhood to adulthood to old age. I think we have a fair amount of information going from childhood to adulthood, but not from adulthood to old age. Now, generalized epilepsy, which usually starts in childhood or early adulthood, it most likely improves with age, although clinical features of generalized epilepsy in elderly are poorly reported in literature. There are rare reports that show that generalized epilepsy can actually worsen around age 50 for unknown reasons. We do not have much information on evolution of focal seizures with age, however. In females, though, data on the effects of menopause on epilepsy are scarce. In general, menopause appears to have limited effects on seizure control, with the possible exception of women with catamenial epilepsy, who may experience an increase in seizure frequency during in the perimenopausal phase, but a decrease after menopause.
Okay, interesting. So what medication-related issues should patients with epilepsy discuss with their neurologists as they draw closer to old age? Things like dosing changes or changes to simplify medication regimens, things like that. What are some of the key discussion points that, as someone is 55, 60 years old, they should be talking about their neurologist or talking to the neurologist about?
Sure. So, if you have been seizure-free for a couple of years, then certainly simplifying medication regimen can be considered. However, this is a very complex issue and should be discussed with the neurologist. As we get older, the kidneys and liver become less efficient at excreting the medications, and this can lead to higher level in the body. But again, as we say, that we should treat the patient and not the levels. So if the patient is experiencing side effects on the same dose of medications, then decreasing the dose can be considered, but it should not be done just on the basis of levels alone. If 2 or 3 times a day medication can safely be changed to once a day formulation of the same medication, then I think it can be helpful with compliance. And then we discussed previously the long-term side effects of certain anti-seizure medications can be problems with bone thickness, and so these patients, again, if possible, should be converted to newer anti-seizure medications. But sometimes, or many times, I would say, it can be complicated and not easily possible.
And I would imagine you probably run across reluctance by some patients who've maybe been on Dilantin for their whole lives, and it's worked for them, and they've been seizure-free, and I would imagine some people are very reluctant to, mess with that if it's been working, even though there may be some long-term side effects that are undesirable. Is that kind of what you've experienced?
Yeah, I think you have hit the nail on the head. Yeah, I think many times we do see patients who've been on Dilantin or carbamazepine for a long, long time, and it's worked wonderfully for them to control seizures. But but these are not the best medications for long-term side effects. And as you said, they are reluctant to change and to a newer medication, which is completely reasonable. But this is again a matter of discussing the risks and benefits with the patient. I would say most people tend to stick with what has already worked for them. It's rare for somebody to want to change to a newer medication.
Right. So does having epilepsy for many years change the types of health screenings that someone should receive and the age at which they should be administered?
So as we discussed, bone health and vitamin D deficiency should be screened regularly in patients on older AEDs. And American Academy of Neurology recommends a DEXA bone scan every 2 to 5 years. While we know that patients with dementia have a higher risk of seizures, and patients with dementia can start having memory problems, patients with dementia and seizures can start having memory problems much earlier, we do not know if seizures lead to increased risk of dementia. And so I think memory should be screened for in appropriate circumstances like self-reported or family-reported memory. I would also like to add that depression can sometimes be a very common source of memory problems, and we know that depression is common in patients with epilepsy. So both anxiety and depression, I believe, should be screened frequently in appropriate patients.
Okay. What about vascular disease? Is there just because some of the older medications may have some impact on that, is that any unique screenings or changes to the standard screening for vascular disease?
I would think not. I think vascular disease, or what is usually checked as a marker for vascular disease is your lipid profile, and that is usually done by the primary care doctor. They are very good at doing that, so I don't think that necessarily has to be looked into by the neurologist.
Okay, great. In your experience, what are the biggest challenges older adults with epilepsy face in terms of Medicare coverage for epilepsy-related healthcare services? Like, what are some of the most common things that they have difficulty getting covered?
So, some brand name medications may not be covered by Medicare. A 2013 study found that Medicare Part D plans provide lower levels of coverage for anti-seizure medications than commercial health insurance plans. And as we just discussed, newer medications are better tolerated by elderly, but some of these might not be covered. The second problem is obviously being in the donut hole of coverage, and most plans with Medicare Part D do have a coverage gap. Home health care coverage for nurses to visit the patient house for help with medication adherence can also be a challenge.
Okay. Other standard things, though, that patients with epilepsy might need, like video EEG monitoring or surgery or that type of thing, is that generally fairly well covered by Medicare?
Yeah, so I think video EEG monitoring is usually covered by Medicare. Personally, in my experience, I have not had many elderly patients who've gone for epilepsy surgery.
Sure.
So I do not have much personal experience with that.
Right. Okay. So many seniors with epilepsy will eventually need some kind of in-home care or respite care or care in an assisted living facility or nursing home. Do you have any recommendations to help families prepare for this? And then also, what can families do to ensure that the staff providing the care are able to respond appropriately to seizures and then effectively assist with treatment?
Elderly patients who have uncontrolled seizures should ideally be living with family or in an assisted living facility or nursing home. This is all the more important if they also have memory problems on top of seizures. Now, if they need to be in a nursing home, then it's important to plan early and make sure there is adequate insurance coverage. For patients who are already in nursing home, Usually, medication compliance is not an issue because they are given the medications by the staff there. However, it can be difficult to get accurate information regarding seizure presentation and frequency, and it is extremely helpful for physicians if a detailed written history is sent with the patient at each visit. Now, there should also be a definite and written treatment plan, which is discussed by the nursing home, patient and family, and physician on when to intervene with medications and when to send the patient to the hospital in case patient has a seizure. It would also be immensely helpful for optimal management that the nursing home or family member contact the physician after every seizure and not wait until the next clinic visit.
Okay. One other question I had was, and you can choose not to answer this if you wish, but I just wonder, is there a bias in the medical community overall where maybe not as much care or concern is given to older adults, and maybe the level of care may not be quite the same level of care that younger adults get or children get? Again, I have no evidence to support that. But I'm wondering if you have experienced that in the medical community at all.
I would say that I think there is a bias, but I think the bias is more for people who are in a nursing home.
Okay.
I think they don't get the same level of care as even in community living elderly. I think not having a family member or friend advocate for the patient, I think makes a difference in the level of care that these people get.
Right. Okay. So before we open it up to questions, do you have any closing thoughts for our listeners?
Yeah, I think I would just like to summarize some key points from our discussion. First, it is common for seizures to start in older adults, especially if you have dementia. The seizures might be difficult to diagnose and differentiate, and so referral to an epilepsy specialist or a comprehensive epilepsy center should be strongly considered. The good news is that seizures seem to be better controlled and less frequent in elderly. However, seizure-related comorbidities, including Statusepilepticus, falls, medication side effects are significant. Also, strongly consider starting elderly patients on newer anti-seizure drugs and increase the dose slowly. It's good to start low, go slow, and then remain on a low dose, as we know that many elderly patients need overall a lower dose to control seizures. I think that's it.
Okay, excellent. Well, a lot of good information. So let's open it up to questions and discussions. Okay. So does anyone have any questions for Dr. Marawar?
Okay, this is Gary from Southgate. Good evening, and nice to be with you. Okay, now you brought up an issue about either assisted living or nursing home. Is that absolutely written in stone that this has to be done or not? Second part is this: now with seizure medication, and there's multiple disabilities. What about the disability that's used for the secondary issue? Could that cause a problem? And third would be, as far as medication is concerned, should the patient have an active role in, as far as the dosage and other information regarding the individual medication and or medications?
Okay, thank you. So let me answer your first question first. I do not think that it is mandatory it is compulsory for patients with elderly people with seizures to be in a nursing home or assisted living facility. But if no one's if you have seizures and you don't have any family around or friends around who frequently check on you, it might be dangerous to be living alone. For example, you might have a seizure, fall down, and not be able to call help. So while it's recommended that if you have seizures to be in a facility, but it's by no means mandatory. For your third question, yes, patients should have an active role in along with their physicians in deciding what medication to take. I would say at that point, however, I would trust the physician on figuring out what dose works for you. Obviously, you should always be vocal about having any side effects. If you are having side effects, make sure you tell your physician. A lot of times, patients are afraid to bring out side effects as a topic of discussion, feeling that they might disappoint the physician or make the physician angry. But please don't do that. Always tell the physician if you're having side effects, and they can then work with you to figure out the dose. Can you repeat your second question? I don't think I got that.
Okay, basically it was about monitoring. You mentioned that persons should consider, like you said, it's not etched in stone, but the fact that the patient should be informed and have options to say, like a fall detector, where you can get it to, say, like a security company, where they, if you fall, they call someone, and then from that point, a decision's made as to whether or not paramedics are to be sent in. And now with the fact that you have camera equipment that you can interlink through the internet, where somebody getting an alert, say from the security company, they can actually go to the internet and say, okay, listen, Johnny's coming out of it. We'll keep an eye on him for a couple of minutes, and then we'll make a decision as to whether or not a advanced medical team should be dispatched. The one thing that I think is a good idea with this electronic equipment is this. One, it keeps the patient in the loop for a much longer period of time. Second, it's not like bang, bing, bang, boom. We're going to take you to an emergency room. But if there's, say, someone that knows that person and say, okay, listen, he is starting to come out of it. He is starting to be coherent. Let's hold off 15, 20 minutes, see what happens. If he comes out of it, then, we don't have to call paramedics. Also, the one thing is this. If you're taken to an emergency room, you're hoping that the doctors are familiar with epilepsy and have access to a qualified neurologist on staff or on call. But if so, you have some facilities that will say, like, our emergency people are good enough, take it or leave it.
All right. So you've raised a lot of key issues there. I think to the first point, the fact that there are a lot of newer technologies that can be really helpful for people with epilepsy trying to be as independent as possible. seizure detection systems and alert systems, like you mentioned, fall detection systems. So definitely that can be an important tool for someone who's trying to maintain their independence. And then the other key point you mentioned is that emergency rooms, which I'm guessing, Dr. Marawar, are probably used maybe more often in older adults with epilepsy. There may be more of a kind of knee-jerk reaction to call 911 if someone has a seizure. There's probably a lot of variability in terms of how prepared emergency rooms are to deal with seizures and epilepsy in older adults.
Yeah, I mean, I think I would imagine that, as you mentioned, there is a more likelihood of paramedics being called in elderly. But I also agree that you don't have to go to the hospital for every seizure.
Right.
As you just mentioned, that if the seizure has ended and you are slowly coming out of it, you don't really need to go to the hospital. Obviously, if you've had an injury or a fracture or something like that, then yes, you should. But but most of the seizures are they stop spontaneously and people come out of it slowly. So you definitely don't have to go to the ER for every single seizure.
Okay. Other questions?
Okay, I was wondering, I know he mentioned that myself personally have been on Dilantin for over 15 years. Okay. You were saying something, I don't know, that it would be best to maybe update it or, change it or get into something else. And I was wondering, could you explain that a little bit more to me, please?
Sure. So as we discussed, Dilantin is a very good medication for controlling seizures, but it can have long-term side effects, especially high cholesterol and making your bones thinner, making you more susceptible to fractures. So those are the two main long-term side effects. Now, the newer medications, a lot of newer medications don't have those side effects. So you could potentially think of changing your Dilantin to a newer medication. However, the risk with that is that just because you have responded to Dilantin does not necessarily mean that you will respond to the newer medication. And so there is this, this is the kind of discussion that you need to have with your physician about what are the risks and what are the benefits of changing to a newer medication. Now, if you've been seizure-free for a long time, you can always think of coming off the medication completely, and that carries its own sets of risks, but that is also an option.
Oh, because I was always assuming that since I was under the impression that I haven't had a seizure since 2000. Last seizure I had was like in 2004.
Wow, that's great. That's amazing.
That's wonderful. And so it's 14 years since you had a seizure.
Right.
So I think it's definitely worth having a discussion with your neurologist whether you can come off the medication completely.
Okay. Thank you. Thank you very much. I will have the discussion with him.
Absolutely.
Just to follow up on that question, what are so obviously the number of years you've been seizure-free is one factor in determining whether you would wean off medication, but I imagine also the type of epilepsy you have and to some extent your interictal EEG might play a role in that determination as well? Or can you talk a little bit more about what other factors would affect whether you would consider weaning off medication?
Okay.
Sure.
That'd be nice.
So that is a complex decision.
Yep.
But the type of epilepsy, whether you have generalized epilepsy or focal epilepsy, how easy or difficult was it to get your seizures controlled? How many medications you needed to control the seizures? What does your recent EEG look like? What is the cause of the seizures? So there are a lot of factors which can influence influence whether you can come off the medication or not. But certainly, the duration, the longer you've gone without having a seizure, does give you a high chance of success.
Okay.
Because the reason I had it because I had a brain tumor. What is I might be not pronouncing it right. A mengione. I had the brain tumor. That's what it had caused. Me to getting the effect of having seizures. And mine just normally was a grand mal. So when I have a seizure, I end up in in the hospital. I can just be talking and banging. But when I do, I wake up and I'm in in the hospital.
Yeah, and I think you also have to discuss that even if the risk is less, if you do have another seizure, if you come off the Dilantin, would you want that, or would you not have any seizure at all? Those are the things to discuss with your neurologist.
Okay. Thank you again.
Yes, I was wondering, you said something about depression, but I didn't get what all you said. Could you sort of tell me again? Because I've suffered from depression off and on all my life, and I'm 62 now. And I've heard that epilepsy, seizures, can actually, I don't know if be connected is the right word, but, I guess what I'm trying to say is people with epilepsy or seizures, some people like that they're more prone to depression. I don't know if that's the case, but it is with me. Not all the time, thank God, but, sometimes.
Right. So we do know that people who have seizures are more likely to have anxiety and depression. Now, whether that's because of having seizures or whether there's an underlying process that causes both seizures and depression, we don't know. But the important thing is to identify that you do have depression and to treat it, whether that's with medications or with therapy. And it's also important, obviously, to control your seizures, because if your seizures are controlled, your depression is likely to get better also.
I would say so. I got when was it? Last week, a couple of weeks ago. I think it was the last time there was going to be one of these talks. I had 2 seizures that day, so I ended up going to the ER for a while. But I don't know what I was going to say. But I do stay on my medication, and I also have medicine for the depression. That really helps, both do. But I still get seizures. If you get them, you get them. But it could be a lot worse. It really could, and I'm glad of that. That it isn't as bad as it could be. And I'm so happy for you. I'm not sure your name, but you said you didn't get it. The last time you had a seizure, what was it, 2004? Or whatever it was. I'm so happy for you that, you haven't had any since then. Unless I misunderstood, of course. Thank you.
Ma'am, if you're still having seizures...
Yes, right, that's what, I said 2004 was the last time I had a seizure. Yes.
Wow, that's great. Hope you never have them again. I wish that on everybody. Thank you.
Yeah.
It's good of you.
Thank you very much.
You're welcome. Thank you for that about what you said about the seizures and that, the depression.
Yes. So if you're still having seizures, then you should try to optimize what medications you're on. If you're still having seizures after being on a couple of medications, you should see a epilepsy specialist if you're not already seeing one.
I am. I'm on 3 different medicines, and I also have a regular neurologist, and I'll be seeing him, I think, in a couple weeks. And I got to call the epileptologist.
Mm-hmm.
I'll do that tomorrow. What's tomorrow? I think I will. Thank you so much.
Yes, you're welcome.
Okay, other questions?
He must have did a good job.
Yes,
very thorough, yeah. So does anyone have, again, I know we have a lot of adults who are sort of on the border of older adulthood. Does anyone have any concerns or worries as you age with epilepsy, or questions on how to, age well with epilepsy? Any other questions? I just want to make sure we're not ending the call prematurely if people still have questions.
Well, I'd like to open this one up to other people in this group.
Yeah.
And that's like when I mentioned about the electronic equipment. Has people been looking into it, and how can we, as individuals and or get organizations and or from your office made aware of what is or is not available that would work?
That's a great question. Has anyone else had any experience with technological solutions to detecting seizures and alerting people to the fact that someone's having a seizure? Anyone else?
That would be nice, because myself, by me having a grandma, I don't even know when I have a seizure. I know they always have like your alert thing or whatever. What do? You could be somewhere, and like I know you had mentioned about being like an assistant or somewhere, but I can be be here. It just happened. Fortunately, myself, when I did have the last seizure, my sister happened to call, and she noticed that something wasn't right. And she got in touch with my child and say, no, you better go back and check on your mother, because she normally answer that phone or whatever. And then when they came back, they just happened to see that I had fell out. So that is kind of scary that you really, can be someplace. And by me having a grandma, see, with other seizures, you can feel it coming on.
Mm-hmm.
Myself personally doesn't. So that's a beautiful question. Yes.
Well, one thing I can tell you. Go ahead.
I think when a person feels the seizure coming on, that is, I always do this myself, and I suggest it to, everybody that feels the seizure coming on, but of course it's up to you, but feel a seizure coming on, lay down on the floor. Because if you lay down on a couch or a bed or something, you could fall off and onto the floor. But you don't lay on the floor on your side, you're not going to fall, but you're just there.
But that's if you feel one coming on. Myself personally don't feel when a seizure is coming on.
Oh, no. I usually do, but that must be really scary. You don't feel it coming on, and then the next thing you know, you're waking up in an ambulance, or, you're waking up on the floor or wherever you're at. That must really be scary.
I wake up in the hospital.
Wow, that must be scary.
Oh, absolutely.
Mm-hmm. That's definitely a good suggestion, though. If you do have a warning prior to your seizure, that getting into a safe position like that is certainly helpful. And for those who have a VNS or vagus nerve stimulator, and you have a warning, you may be able to use the magnet to activate the device and possibly prevent the seizure. So, yeah, there's a lot of great technological solutions, and actually I encourage people who want to learn more about that to join us on July 11th for our Learn and Share conference call, which will actually be a webinar. So we'll have different call-in information to join that. There'll be you can join it by online on a computer, or you can join it still by phone, even if you don't have a computer.
Wow.
So that's going to be focused on smartphone apps and online tools for managing epilepsy. So that'll be, again, we'll be reviewing all of those new technologies that can help people to detect and seizures and help people to better manage their epilepsy. So that should be a good one.
All right.
Okay. Any other questions?
I would just like to add that I believe FDA recently approved a seizure detection device. It's called Empress. It's like a watch or a bracelet that you wear around your wrist, and it can detect and notify your family if you had a seizure.
Oh. Wow. Okay. That's great.
Yeah, and right now, most of the current devices that are out there, and there are several, are motion-based. So they either detect some go in a mattress, like under a mattress, and they detect rhythmic motion. Some go on your wrist, like a watch-type device. Others are apps that are just right on a smartphone. So if you have your smartphone in your pocket, it will detect rhythmic movement and alert someone. So there's several out there. The biggest limitation right now is that they're really only designed to detect generalized tonic-clonic seizures or grand mal seizures. So people who have complex partial seizures or other seizure types that don't have that rhythmic movement associated with it, they may not yet be able to benefit from those devices. But I'm sure there's a lot more research going into that to see how we might be able to detect other seizure types too. So.
We'll have to do that sometime.
And I was just getting ready to ask about that. Was it just for the grand mal seizures or even non-epileptic seizures?
Non-epileptic seizures, what's that?
What is that?
Well, I experienced sometimes non-epileptic seizures where going to staring, and I don't have petit mal. Sometimes I may have a petit mal seizure, but some of the times is I go into a stare, and I'm sitting up. And I could be talking, then I stop talking, and I go into a stare. I get lightheaded and dizzy. And that's considered a non-epileptic seizure.
Wow.
The brain, inside my brain, the activity is going on, but it's non-epileptic, but it is still considered a seizure.
So there's something called psychogenic non-epileptic seizures, or PNES, and that's it can look like any type of epileptic seizure, but it's actually not caused by an electrical disturbance in the brain like an epileptic seizure is. It's actually psychological in nature. It's an involuntary response to stress. Some stress that you've experienced currently or that you experienced in the past, and it can manifest very much like a seizure, but it's involuntary. It's not something that the person has any control over or that they're doing on purpose. It's unpredictable like epileptic seizures, but it's just a different cause. And the treatment is different for non-epileptic seizures. And also, there are some people who have both epilepsy and non-epileptic seizures, so that can be sometimes confusing to tell which is which. But
that's the first time I heard of that.
But thanks for sharing that. And that is kind of the next step, is how can we detect other seizure types? Tonic-clonic seizures. And I know the Embrace Watch, it has something that can measure electrodermal activity, I believe, and there is possibly some correlation with changes in electrodermal activity, which I think, Dr. Marawar, is that related to basically sweating, or do you know what that refers to?
I think there's a very mild or subtle change in skin temperature. I think that is what it measures.
Okay, right. So there's a possibility that, as they learn more about what subtle changes in the body occur with different types of seizures, they might be able to, change the algorithm so that it can, reliably detect other types of seizures based on these more subtle changes in physiology or in changes in the body. So there's a lot of promising, things on the horizon. It's just it's going to take a while to develop those technologies. But anyways, any more questions, particularly related to aging with epilepsy?
I don't just think it's been, learned some good information. That's all I know.
Well, thank you so much, Dr. Marawar. I think we'll wrap it up now, and thank you everyone for participating and for your great questions. If you have further questions about epilepsy or about this topic, definitely give us a call at 1-800-377-6226, or you can visit our website at epilepsymichigan.org for more information. And our next Learn and Share conference call is on May 2nd from noon to 1:30 p.m., and the topic is the nature of epilepsy from causes to consequences, and the speaker is Dr. John Bunka, who's an epileptologist with Bronson Neuroscience Center. So thank you, everyone, again, and thank you so much, Dr. Marawar, for a very thorough and enlightening discussion.